Good afternoon, dear friends, colleagues, and also our special guest from France, Professor Gabriel Steg. Today, it's a big honor for me and also Dr. Bambang Budiono as a co-chairman to moderate a very interesting distance learning topic on interventional cardiology. And the title will be the Optimizing the Benefit of Antiplatelet Therapy in the High-Risk Post-PCI Patient. Dr. Bambang Budiono will help me to moderate the session. Dr. Bambang, please you introduce Dr. Doni and we will start the first speaker.
Yeah, thank you, Dr. Sunaria. Good afternoon, everyone. Dr. Doni Firman will bring up current issues, especially in Indonesia, regarding PCI in ACS during COVID-19 era. What can we learn? Without further ado, I'd like to invite Dr. Doni to share his views concerning this issue. Dr. Doni, please.
Thank you, Dr. Sunaria, Dr. Bambang, for the nice introduction. So it's been an honor for me to talk in same state with Professor Steg. So my duty this afternoon, so I will talk regarding the PCI in acute coronary syndrome. And then, of course, we know due to the pandemic, there is some changes, big changes already happen all around the world, and also including Indonesia, of course. So so my talk is going to be short because just an introduction. I think my talk will not last until 20 minutes. I hope so. So we know that COVID-19 pandemic showing a big impact on the diagnosis of treatment, especially in patients with acute coronary syndromes. And then we must put in our mind that the infection status of each new patient very, very important to us, how to make it or to help reduce the spread of the infection. And then, of course, it's also important that we must provide our healthcare workers, including us and our nurses, the proper PPE, especially in the lab. So this is my slide. In Indonesia, we often see it almost every day. This is in Indonesian language, in Bahasa. You can see every day the new cases still rise. I don't know what about in French. I think is probably much more stable comparing in Indonesia. And then so far we have around 60,000 cases, and then 3,000 died. So the case fatality rate is around 5%. So we know in the beginning of COVID-19 in Indonesia, we started this pandemic around the end of the February of the early week of March. We learned that initially that COVID-19 will affect only to the lung or respiratory tract. And then we also learned lately that COVID-19 also have a direct effect on the myocardial. And then we also learned in the latest weeks that the COVID-19 also have related to the atherothrombosis. Might be it will impact the pulmonary artery, but also even in the coronary artery, and then will induce acute coronary syndrome. And if we have a patient with CV comorbidities, it's very common, especially with the aged patients. And then some data already reported that the presence of CVD associated with increased mortality in COVID-19 infection. The other phenomenon that we know, we read from the journals, mentioned that in some part of world, let's say in northern Italy, already reported 58% increased in out of hospital cardiac arrest comparing in the same period in the last year. Also in France, I think Prof. Steg will know better than us that they also reported the higher out of hospital cardiac arrest comparing in 2019. And even if the patient admit to the hospital, the survival is very, very low. In the United States, already reported that estimated 38% reduction in cath lab laboratory, especially for STEMI patients. And then we really appreciate some of us in Indonesia, starting in early of March, we're still doing primary PCI, even though we know that at the time we still very, very terrified, and then we didn't know exactly what to do because lack of information. And also at the time, the way we screen the patient is so bad. We just rely on the historical anamnesis from the patients. But now I think we're slightly better than comparing with the early of March. So we can see all the colleagues from Sumatra, from Java, and also from Sulawesi still doing primary PCI during COVID-19. So what about in Indonesia? So the data, we're still collecting the data from all over Indonesia, but still we behind the time. But anyway, I will try to provide you the data from my hospital in the Harapan Kita, National Cardiovascular Center. If we compare this line, comparison of total STEMI cases or admitted in the emergency ward, you can see in 2019 the red line showing the number is relatively stable between 60 to 80 patients per month. But if you look at in the recent days, you can see starting for the February, maybe the last week of February, they start getting down, and March and even April, the STEMI cases in us is around 50% comparing in 2019. In May also, but in June we hope that this number is getting better. The last information I received that is already reached, let's say, around 60 to 70% comparing the last year. So what about the STEMI management? Of course, we learned from the EC guideline. You know that Indonesian Heart Association copying the EC guideline, and then is already around Indonesia. We know that the STEMI management goal is how to reduce total ischemic time. And total ischemic time rely on the first the awareness of the patient, and then the ambulance system of the city maybe, and then we try to reduce the door to ischemic time by reducing door to balloon time less than 90. And I know the EC guideline mentioned it's less than 60 minutes, but in Indonesia I think we're still in. We hope we can reach door to balloon time less than 90 minutes. So the other thing that we face in Indonesia, and I also know regarding this issue, there's some fearness of COVID-19 patients, because EC report that more than half of the heart attack patients away from hospital means that they still try to not to go to the hospital, and that could be fatal for the patient itself. So there's some reason for decreased ACS admission in our emergency ward. One of the fearness of being exposed to COVID-19, and then the second is some worriness about the burdening of the healthcare system due to this pandemic. And then the third one, maybe in some part the patient not leaving their homes due to the government restriction, maybe to the what we call it lockdown. And then we also know there is some changes. EC recommend us to do the pathway. If the patient come to ER access, so we must screening the patient whether the patient has a fever or respiratory symptoms of a history of previous contact with other COVID patient or any other family history of COVID infection. If there is no COVID, so the patient can go as usual or daily routine basis. And then if the patient has a COVID infection possible, that creates some problems. So if the patient need a hospital admission, so we must be sure whether we should put patient in special ward or COVID isolated ward or not. So it depends on the screening capability of each hospital. So what about in STEMI? So there is some extra delay expected. In Europe, they expect around 60-minute extra delay. Mean if you want to have a 120 minutes from the first medical contact to cath lab, so you must add around 60 minutes before the patient coming. Whether if the patient go for primary PCI or go for fibrinolysis. And also most important that any STEMI patient should be managed assuming positive for COVID-19 status. So it should be applied all over hospital, including in Indonesia. So again, even the EC mentioned that the COVID-19 pandemic should not compromise timely perfusion of STEMI patient. But even though we know that it's very, very difficult for us, because concurrently, we must be sure as well that safety of us, healthcare providers, should be ensured. And also we must be sure we must doing proper screening for each patient coming, especially patient with STEMI. So in the last week of March, the Indonesian Medical Association launched the protocol of COVID-19 management, but it is also 3 months away. So I think we must revise this protocol as soon as possible. So the protocol for each hospital is different. Indonesia also is depend regarding the screening capability of the hospital and also the PPE in each hospital. If you look, this is from just the example of my hospital. The patient coming, so it must completed epidemiology from inquiry form, and then you must, divided the patient whether asymptomatic or not. If patient COVID positive, sorry, in my hospital, we're still doing fibrinolytic. If not, so all a patient must come in to the cath lab, and then after a patient got primary PCI, so the admission award rely on the rapid test. So this is also a journal with the 141 respondents all over the world, showing that 62% of respondents declare a STEMI patient presented later than usual. And then also in Harapan Kita, this is slide actually showing the same data. If you look at the right side, we have relatively increasing STEMI with more than 12 hours onset, especially in March. In April, it looked same, but you know that in April, the number of patients coming in emergency ward is really declined. So it's not really comparable. So in May also, you can see there's some increase in patient STEMI with late onset. The same thing also reported in Ireland, that there is some increasing in the symptom to first medical contact and total ischemic time. Same report also in insight from British Cardiac Society in some hospital in UK. But I must admire, even the ischemic time is increasing, the door to balloon time in those hospitals is still good comparing to the before COVID area. I think not every of us can achieve that number. If you look at the ischemic time STEMI in my hospital, comparing to the last year, we can see there is some increasing ischemic time significantly starting in March and April, and then it's going to be better in May and June. So what about the door to balloon time? Is affected so much because we still try to find how to decrease the door to balloon time in the matter of how to screen the patient as fast as possible. So right now we just rely on the historical taking and also to the rapid test. But if you look at the door-to-balloon time in my hospital, comparing to the last year, you can see the comparison is almost 4 times or 5 to 4 times higher in terms of door-to-balloon time. So mortality, I think maybe is not comparable, but I've mentioned before the number coming in this month. These 3 months is really decline. And then if you also we must put in mind in patients is with coronary artery disease and heart failure, because patient will coming with in the late stage, maybe at a particular risk as a result of coronary plaque rupture, secondary to viral induced systemic inflammation. And we need rigorous use of plaque stabilizing agents like aspirin, starting beta blocker, ACE, or whatever that our usual guideline mentioned. And then we know due to the systemic inflammation happen in COVID-19, so we also like to intensify our antiplatelet therapy in those patients, especially patients staying underwent PCI. So of course there is some also discussion about the role of corticosteroid, but still we need more data regarding those issues. So this is my last slide. We know that there is no single solution for all invasive services and networks in the COVID-19 pandemic, including in Indonesia. So there will be a variation of the restriction according to the stage of the crisis. And then we know all over the world, patient presenting, STEMI presenting in our emergency ward must be had a longer total ischemic time, might be driven by delay from onset of symptoms to first medical contact, because the patient really hesitate to go to the hospital. And then also the potentially due to the isolation or reluctance to engage medical services due to fears of regarding of COVID-19. I think this is my last slide, Dr. Bambang. Thank you very much for attention.
Thank you very much, Dr. Doni, for the wonderful talk and very informative. And then I think Dr. Sunaria will be chairing the next talk. Please, Dr. Sunaria.
Thank you, Dr. Bambang Budiono. And now we will have 1 hour lecture presentation from our outstanding speaker from France, Professor Steg. We really want to hear your presentation. Thank you.
Finally, I really want to thank you for giving me a platform for a long talk. The issue of antiplatelet therapy post-PCI is an important issue. It's a complicated issue, and there are many sides and aspects to it. And I will try to discuss in this conference many of the historical aspects as well as the most recent findings from clinical trials in the field, and to come up with a synthesis based on guidelines and evidence on how to best approach antiplatelet therapy in PCI patients. These are my disclosures. I've been doing clinical trials for many years and have interacted and received honoraria from many of the pharmaceutical companies that manufacture drugs in the cardiovascular field, including AstraZeneca, our host today for this session. So let's start with a little bit of history. Dual antiplatelet therapy after PCI. Why do we use dual antiplatelet therapy after PCI? Well, it all started with the need to prevent stent thrombosis. And in the 80s and 90s in the previous century, we had stents, but we couldn't use them because we had very high rates of stent thrombosis, despite using aspirin and anticoagulant therapy and heparin. So we had patients receiving heparin, aspirin, warfarin, they were bleeding, and still they got high rates of stent thrombosis. And it was not until we added a P2Y12 inhibitor, thienopyridine, to aspirin, that we were able to get rid of stent thrombosis, or at least minimize the risk dramatically, as shown in these 2 large-scale randomized trials published in the New England Journal of Medicine. And since then, it's been accepted that any PCI that ends with stent placement requires some period of dual antiplatelet therapy combining aspirin and a P2Y12 inhibitor. And then we got interested in using dual antiplatelet therapy in ACS and post-ACS. And then trials in post-ACS demonstrated that there was benefit of DAPT and even potent DAPT, even if there was no stent placement. And this started with the CURE trial in non-ST elevation ACS, showing that adding clopidogrel to aspirin reduced clinical events after ACS compared to aspirin alone. And this was in an era where stent placement was done only in the minority of patients. So many of these patients were managed medically. And the benefit started very early in the first few hours after randomization. Well before a stent was placed, there was already benefit of clopidogrel plus aspirin compared to aspirin alone. Similar studies established benefit of clopidogrel added to aspirin in STEMI patients. The CLARITY trial, which was a post-lytic therapy trial, and then the COMMIT trial in China established benefits, clinical benefits of adding clopidogrel to aspirin in STEMI. Now, clopidogrel and aspirin was a very effective therapy, but as we know, clopidogrel has substantial limitations related to its metabolism. It needs to be absorbed by the GI tract, and then it needs to be metabolized into an active agent by the liver. And as we know, this metabolism is genetically determined, it's highly variable, it is slow, and it can be quite inefficient in some patients. And this led to the development of alternative agents, prasugrel and ticagrelor, which either had a much faster and efficient metabolism by the liver, or did not require biotransformation in vivo and just needed to be absorbed to be effective. So yes, clopidogrel has limitations: slow onset, slow offset, variable efficacy largely related to variations in metabolism, and moderate P2Y12 inhibition. Now, the first of the agents that was tested in clinical practice was prasugrel in the TRITON trial, a PCI trial in ACS patients, which showed that adding prasugrel to aspirin reduced CV deaths, MI, and stroke at the expense of an increase in TIMI major non-CABG related bleeds. The absolute magnitude of the benefit, however, was much larger than the increase in bleeding. Of note, there were 3 subgroups of patients in whom the net clinical benefit analysis was not as favorable. These were patients with prior stroke or TIA in whom there was actually harm from treatment, which means that these patients are contraindicated to therapy with prasugrel. And 2 subgroups in which treatment did not appear to yield as large a benefit and maybe as safe a treatment, which are patients of an age of 75 or more and patients with a low body weight of less than 60 kilograms in whom either the dose should be reduced or alternative therapies should be considered. The second treatment to be tested compared to clopidogrel was ticagrelor in the PLATO trial, another large-scale ACS trial, not solely PCI, was also medically managed and CABG managed patients. And again here, ticagrelor proved superior to clopidogrel with a 16% relative risk reduction in the primary endpoint of CV deaths, MI, stroke. Note that in contrast to what was seen in the TRITON trial, the benefit appeared steadily over time. It appeared to accrue over time, whereas in TRITON, the benefit was established early and maintained over time. An important observation in PLATO was a significant reduction by approximately 20% in the risk of cardiovascular mortality, which was statistically significant. And that is an important observation. Note the magnitude of the benefit in absolute terms, almost 2% in CV deaths, MI, and stroke, and 1% for cardiovascular death. This is the absolute benefit. Note that the event rates are in the range of 12% and 5%. Now, I like to joke, why would one not use a drug reducing mortality? And you know, it's a little like this game show where you ask an obvious question and you wonder why people might answer the wrong answer. I think if you have a drug that reduces mortality, there is compelling evidence to support its use. Now, one important additional observation is that in both in the Triton trial with prasugrel and in the Plato trial, both prasugrel and ticagrelor reduced stent thrombosis, and there was a significant reduction in stent thrombosis. But I want to highlight that the bulk of the events were not stent related. If you look at the event rates for stent thrombosis, it's 2% in the clopidogrel plus aspirin arm, whereas you'll recall that the absolute event rate for the primary outcome was 12%. And so, yes, there is a benefit in stent thrombosis, but that does not drive the overall benefit of ticagrelor. There are many other benefits than preventing stent thrombosis. And this reminds us that we are treating patients, we are not treating stents. I sometimes hear colleagues saying, why do we need to use ticagrelor or prasugrel? Clopidogrel works pretty well and now stent thrombosis rates have declined. Well, the reality is that stent thrombosis is not the issue, no longer. It's only a minute fraction of the total number of ischemic events that patients experience. Now, there was a price to pay in Plato as well with bleeding, with increased non-CABG related bleeding with ticagrelor, but the net clinical benefit was statistically favorable. The number needed to treat to prevent one primary composite endpoint is 54. The number needed to harm to create one major bleed is 250. Another observation is that we often discuss DAPT, but I think it's wrong to use the term DAPT. DAPT is a misnomer. The reality is that we know we have strong evidence from Triton that aspirin and prasugrel is better than aspirin and clopidogrel. And we also have strong evidence from Plato that aspirin and ticagrelor is better than aspirin and clopidogrel. So why do we call them all DAPT? There's low intensity DAPT and high intensity DAPT, maybe, but certainly not DAPT. We also have had evidence in post-MI, in high-risk post-MI, that there might be benefit to DAPT. And this comes from the large-scale, double-blind, randomized Pegasus trial, which enrolled high-risk post-MI patients to receive ticagrelor plus aspirin or aspirin alone, using 2 doses of ticagrelor, 60 milligrams BID and 90 milligrams BID. As I'm sure you're aware, this is a fairly high-risk patient population with a 3-year event rate of 9%. And there was a consistent benefit of both ticagrelor doses, 60 and 90 milligrams, compared to placebo when added to aspirin, with approximately a 15% relative risk reduction. Note that although the efficacy appeared similar, the safety was slightly better with 60 milligrams, which led to the approval of that 60 milligrams BID dose with ticagrelor. However, there was bleeding. There was approximately a 1 to 1.5% increase in TIMI major bleeding, but fortunately no increase in fatal bleeding, intracranial hemorrhage, or fatal bleeding with ticagrelor when compared to placebo. Now, let's get to the issue of DAPT duration after DES. Generally, 10 years ago, the gospel was, if you do PCI and you place a stent, you need to give 12 months of DAPT, regardless of whether this was for an ACS or whether this was an elective PCI. And the question soon arose, can we abbreviate DAPT duration because it's inconvenient? Patients take many pills, they complain of bleeding, they sometimes need to undergo procedures, dental, urinary, GI, and it's a hassle and inconvenience, and maybe it's dangerous because of the bleeding risk to prolong DAPT. So that led to a series of randomized trials, many of which are summarized in this slide, which looked at comparing shorter durations, 3 to 6 months, to long durations of at least 12 months after coronary stenting. And to summarize the findings in brief, what these studies found is, number one, there's a reduction in major bleeding when you abbreviate DAPT duration. which is not surprising. And there doesn't seem to be a price to pay in terms of risk of myocardial infarction. So therapy, shorter therapy seems to be safer and probably at least as effective. Many of these trials were non-inferiority trials and concluded for non-inferiority. Now, there are many studies, but I want to highlight a few points. Number one, even if you pool these studies in a meta-analysis, you can note that the confidence interval for the observation of the treatment effect is pretty wide. We cannot exclude a 45% increase in the risk of myocardial infarction. So we certainly cannot rule out that there is decreased efficacy with short compared to long therapy. Number two, there are other options than shortening therapy. Maybe we could decrease the intensity, so-called de-escalation of antiplatelet therapy after 1 month. This small French trial suggested that maybe you could switch ticagrelor, prasugrel to clopidogrel 1 month after ACS and get away with it. The primary endpoint of this small trial was a composite of ischemic endpoints and bleeding and showed a reduction in the primary efficacy endpoint. But note that this was not related to a difference in ischemic endpoint, was entirely driven by the reduction in bleeding, as would be expected. I want to highlight additional limitations of the DAPT duration trials. The non-inferiority DAPT duration trials are often based on expected event rates in the reference arm and planned non-inferiority margin based on that expected event rate. Let me take an example. In the EXCELLENT trial, the expected event rate in the reference arm was 10%. And the authors planned a non-inferiority margin of 4%, which corresponds to 40% of the expected event rate in the reference arm. However, what they observed in real life was that the event rate in the reference arm was not 10%, it was 4%. And therefore, maintaining a non-inferiority margin of 4% means that you accept an actual increase of 100% in ischemic events as being non-inferior, something that most clinicians would probably object. Second limitation, almost all of these shorter duration studies were open label studies. And in an open label study, a problem is that you have many crossovers, and the crossovers are not randomly distributed between arms. Because investigators and patients know which treatment they're taking, they will tend to stop the most intensive treatment that creates more bleeding and to continue the less intensive treatment. And therefore, crossovers will be asymmetric. A second option, because many of these trials were small, the numbers of patients lost to follow-up may be substantial. They are depicted in red in this slide. And I think it's interesting to plot the number of crossovers in orange, the numbers of patients lost to follow-up in red, and the actual number of outcome events on which the conclusion of the trial is based, to look at how reliable these conclusions are. And I want to point out that I'm not criticizing the author's work. I include in this criticism a trial that's a French trial in which I participated called OptiDual. The problem with many of these trials, as you can see, is that there are larger numbers of crossovers, small number of outcome events, and very substantial numbers of patients lost to follow-up. And therefore, the reliability and the robustness of the conclusions based on the green is small. Now, this is not true for all trials. To be fair, there are some trials such as RESET or Prodigy, where there are a much larger number of outcome events than there are lost to follow-up and crossovers. But as you can see here, this is the exception rather than the rule. And if you look at the largest trials that looked at DAPT durations for shorter DAPT durations, they actually demonstrate a potential harm of shorter DAPT duration. This is the SMART DAPT trial that randomized almost 3,000 patients to 6 versus 12 months of DAPT. And as you can see, there is no significant reduction in bleeding. There is no difference in MACE, but there's actually a significant increase in myocardial infarction that seems to appear right at 6 months at the time of discontinuation of DAPT in the experimental arm. Now, does this mean that longer DAPT duration is better? Well, we also have trials that have looked at longer DAPT duration. The first one, and the largest one, is the DAPT trial. Almost 10,000 patients with a double-blind trial comparing thienopyridine versus placebo from month 12 to month 30 post-stenting. The first co-primary endpoint was stent thrombosis, and even though event rates were low, it was significantly reduced by prolonged DAPT, 0.4% versus 1.4%. So an absolute benefit of 1%, a relative risk reduction of 70%, highly statistically significant. The co-primary endpoint was MACE, and there was also a significant reduction in MACE, 4.3 versus 5.9%, significant, a relative risk reduction of almost 30%. Note that when double-blind therapy was stopped at month 30 and DAPT was stopped in the green arm, there was a blimp in the curve that seemed to go closer to the placebo curve. So it seems that whether you discontinue at 12 months in the blue arm or at 30 months in the green arm, you pay a price whenever you discontinue DAPT. A small price, but you pay a price. There was an excessive bleeding in the longer duration arm, approximately a 1% increase in severe or moderate bleeding. And there was no difference in all-cause mortality at 30 months, at least no significant difference, although there was actually a strong trend going in the wrong direction with actually a numerically higher mortality in the thienopyridine arm compared to placebo, possibly related to bleeding, although we don't have definite proof of that. Note that when DAPT was discontinued, there was actually again a blip in mortality, and now it became significant. So how do we make sense of this conflicting evidence in favor of shorter versus longer DAPT duration? So let's discuss a number of issues. First of all, the clinical context may be critical, and it's certainly very important to look differently at patients who had ACS or high-risk MI versus patients who have elective PCI. This is an analysis of the DAPT trial that looked at stent thrombosis, myocardial infarction, and bleeding as a function of the clinical context at baseline. You can see that for efficacy, the number needed to treat versus the number needed to harm is actually much smaller for ACS than it is for non-ACS. Whereas the number needed to harm here for bleeding is actually almost the same. So you get a much better deal if you prolong therapy in ACS patients in terms of prevention of ACS, prevention of stent thrombosis and prevention of myocardial infarction, whereas the increase in bleeding is almost the same. Second, there was a meta-analysis of long-term DAPT for secondary prevention of cardiovascular events in patients with previous myocardial infarction. This is a collaborative meta-analysis of randomized trials. And as you can see here, compared with aspirin alone, DAPT for more than 1 year among stabilized high-risk patients with prior MI decreased all of these ischemic events, including significant reductions in the individual endpoints of CV deaths, recurrent MI, stroke, at the expense of an increase in major bleeding, but no increase in fatal bleeding, no increase in non-cardiovascular deaths, and overall, a numerical benefit in all-cause mortality here. So this would suggest that in post-MI patients, we should seriously consider extending DAPT for secondary prevention if patients are at low risk of bleeding. Another clinical setting that may influence the benefit of DAPT duration is diabetes. We've known that diabetic patients are at particularly high risk of ischemic events, and that they have a strong propensity for thrombotic complications. Both in Plato and in Pegasus, we observed that they had much higher event rates than non-diabetic patients. You can see here the comparison of the treatment arms for ticagrelor and placebo in Plato between diabetic patients and non-diabetic patients for the primary endpoint, for all-cause death, and note that there is a higher rate of bleeding overall in diabetics, but no increase in the excess bleeding related to ticagrelor. In fact, if anything, there was numerically less bleeding with ticagrelor in diabetics. If we look at the Pegasus trial, again, a consistent benefit of ticagrelor compared to placebo in Pegasus, both in diabetics and non-diabetics, but note that the event rates are much higher for the primary endpoint, as well as for CV death. And the excess in the bleeding rates was quite similar between diabetics and non-diabetics, approximately 1.5%. Now, these are for ACS patients. What happens in diabetic patients who undergo PCI and haven't had an ACS? Well, this was recently tested in the THEMIS randomized trial, a trial that I was privileged to lead with my colleague and friend, Dr. Deepak Bhatt, looking at cardiovascular prevention in patients with coronary artery disease, type 2 diabetes, but who haven't had an event before, neither prior stroke nor MI. To get into the trial, patients had to have established coronary artery disease defined as a history of PCI in 58% of the patients, or a history of CABG, or at least one stenosis on a coronary angiogram. They were randomly assigned to ticagrelor or placebo in addition to low-dose aspirin. This was a very large trial of approximately 20,000 patients. To the best of our knowledge, this is actually the largest randomized trial ever conducted in diabetes. The primary outcome was CV death, MI, and stroke, and the primary safety outcome was major bleeding. If you look at the primary composite endpoint, you can see that there was a high risk of events and that there was a significant reduction in cardiovascular death, MI, and stroke with ticagrelor compared to placebo of approximately 10%. What is interesting is that, however, that there seemed to be some heterogeneity in the efficacy of treatment and the safety of treatment, depending on whether a patient had a history of PCI or no history of PCI. As you can see here, this is the overall treatment effect here. If you divide the population into the 58% that had a history of PCI, they had a larger benefit of 15%, whereas patients with no history of PCI actually had a hazard ratio of 0.98. The interaction was not significant for efficacy, it was significant for net clinical benefit. If we focus on the PCI population, there's no effect on cardiovascular mortality or all-cause deaths, at least no significant effect. There's a 20% reduction in MI, a 26% reduction in stroke, a 50% reduction in acute limb ischemia or major amputation, and an 18% reduction in the composite of all-cause deaths, MI or stroke. What about safety? Here we plotted in this table the various safety outcomes as a function of history of PCI versus no history of PCI. And what you can see is that generally safety was better in patients with a history of PCI than without a history of PCI. And there was actually a significant interaction for BARC bleeding and for intracranial hemorrhage. There was a significant increase in intracranial hemorrhage with ticagrelor in patients without a history of PCI, and there was no significant increase in patients with a history of PCI. So if we now look at net clinical benefit defined as a composite of all-cause deaths, MI, stroke, fatal bleeding, or intracranial hemorrhage, trying to look at what we call irreversible harm events, you can see that there is a significant net clinical benefit of 15% in the group with a history of PCI, with the curve that appeared to diverge over time, whereas there was no significant benefit in the group without a history of PCI. We also can look at this by events prevented or caused for every 1,000 patients treated for 3 years with ticagrelor. Based on the observations in THEMIS PCI, for every 1,000 patients treated, there were 15 events prevented on the ischemic side, no excess bleeding, and therefore the net clinical benefit is 15 events. In contrast, for patients without a history of PCI, there was no efficacy. There were 7 bleeding events additionally caused by ticagrelor, and therefore a non-significant net clinical benefit trending towards harm. Again, the statistical interaction term was significant, indicating that there is a true difference between these two subgroups. So this suggests that the best candidates for prolonged treatment with ticagrelor, in addition to aspirin among diabetics with a history of coronary artery disease, are patients with a history of PCI, particularly if we can filter out those who have a high risk of bleeding. Now, how long should we treat after PCI diabetics? We looked at the benefit of ticagrelor versus placebo as a function of the time elapsed between a previous PCI randomization. And as you can see, there seems to be benefit for up to 10 years after PCI. Even if you take the conservative estimate and you look at the 95% confidence interval, it doesn't cross the identity line until 6 years. So for a minimum of 6 years, we can be confident that there is benefit of ticagrelor added to aspirin in diabetics who've received PCI and a stent. The interesting thing is that 3 weeks ago, actually a month ago now, the FDA granted an extension to the ticagrelor label. In addition to the indication for ACS and post-MI based on Plato and Pegasus, the FDA added the ability to reduce the risk of a first MI or stroke in patients with coronary artery disease who are at high risk for such events. They pointed out that while use is not limited to this setting of diabetes, the efficacy of ticagrelor was established in a population with type 2 diabetes mellitus, and the references here are the THEMIS and THEMIS PCI manuscripts. Interesting that the FDA granted actually a broader label than what was tested in the THEMIS trial. And as we all know, this is based on additional observations from Charisma, Capri, and other trials. Now, there seems to be a lot of room for clinical judgment in making decisions about DAPT duration. Could we have a formalized risk assessment? So one way to do this is to use scores. And one such score that's been proposed to guide decision-making is the DAPT score, based on patient characteristics and index procedure characteristics. It's a point-based system that ranges from -2 to 10, and the median value is 2. And it's interesting to look at the results of the DAPT trial as a function of the DAPT score. For patients who were below the median, less than 2, there was actually very little benefit of prolonged DAPT in terms of prevention of MI or stroke or MACE, and there was a substantial increase in bleeding. In contrast, in patients who had a DAPT score of 2 or more, there was a marked benefit in preventing ischemic events, significant reduction in MI or stent thrombosis, significant reduction in MACE, and no excess in bleeding. So it would appear that at least in the DAPT trial, the DAPT score discriminated pretty well those patients who derived net clinical benefit from prolonged DAPT compared to those who didn't. There's been a lot of discussion regarding the applicability and the generalizability of the DAPT score. And to make a long story short, there are studies that support it and studies that don't. Another score that's been put forward is the precise DAPT score. Now, the DAPT score tries to predict net clinical benefit. The precise DAPT score tries to predict bleeding. It's a fairly simple point-based system score relying on 5 simple items: hemoglobin, white blood cell, age, creatinine clearance, and prior bleeding. And you have a maximum score of 100, and you're considered to be a high risk of bleeding above the value of 25. Let's look at what happens in terms of benefit of prolonged DAPT duration as a function of precise DAPT score. In red, you have bleeding. And what you're seeing is that if you have a very low, a low or a moderate value of the precise DAPT score, you actually have no increase in bleeding. But you have a value of 25 or more, then you have excess bleeding with harm in red. The ischemic events in white show benefit with some reduction of prolonged DAPT if you have a very low, a low, or even a moderate DAPT score. But if you have a value of 25 or more, then you have a precipitous drop in benefit trending towards harm. And if you now plot the net effect in yellow, there is overall net benefit up to a value of 25 and harm above 25. And this means that if we filter out the bleeders above 25, we can get to the population who derives net clinical benefit. So maybe we can just look at high risk of bleeding and say, patients at high risk of bleeding will not have benefit of prolonged DAPT. Patients without a high risk of bleeding will benefit from prolonged DAPT. Now, I think the jury is still out on which is the best score, and we may not have seen it yet. In my opinion, we are still in the infancy of scores, and we are not at the stage where we are, for instance, in anticoagulation in AFib, where we can use the CHAS-VAS score to guide clinical decision making. And maybe this is all obsolete, because maybe we don't need to use DAPT. Maybe the future is to use long-term monotherapy with a P2Y12 inhibitor, dropping the aspirin. Our whole thinking for 25 years has been to say the foundation therapy is aspirin, and we add ticlopidine, clopidogrel, prasugrel, or ticagrelor. But maybe we should reverse our thinking. Maybe we should think that what is essential to preventing stent thrombosis and ischemic events is the P2Y12 inhibitor, and maybe aspirin doesn't bring any additional efficacy, it just increases bleeding, particularly as aspirin is toxic to the GI tract. That has been tested in now quite a series of randomized trials. The first trial to test this was the Global Leaders trial, a large 16,000 patients all-comer PCI trial using a drug-eluting stent in which patients received either a year of DAPT followed by 12 months of aspirin, or only 1 month of DAPT with aspirin and ticagrelor followed by ticagrelor monotherapy for 23 months. This was a pretty ambitious trial because the primary endpoint was not CV-death MI stroke, it was a much more stringent endpoint of all-cause mortality and Q-wave MI. The trial fell short. Overall, there was no benefit of monotherapy with ticagrelor compared to DAPT. There was a 13% reduction in mortality or new Q-wave MI, but this was not statistically significant, although there was no excess in bleeding. Quite a disappointment to the investigators, and being one of the investigators, I can testify we were very, very disappointed. Fortunately, others picked up the baton and continued with further randomized trials. The first such trial was the STOP-DAPT trial. STOP-DAPT looked at conventional therapy for a year with clopidogrel and aspirin compared to 1 month of DAPT followed by clopidogrel alone. And as you can see, the primary composite efficacy and safety endpoint showed actually a significant benefit in favor of the 1 month DAPT group compared to the 12 month DAPT group. And this satisfied both non-inferiority and superiority. There was actually no difference in efficacy endpoints, the ischemic endpoints, but there was quite a marked benefit in bleeding. So monotherapy reduced bleeding and maintained efficacy. If we look back at the confidence interval, it's still pretty wide, but the curves appear to quite overlap. A second trial was the SMART Choice trial. Again, looking at monotherapy with a P2Y12 inhibitor compared to 3 months with 3 months of DAPT compared to 12 months of DAPT. If you look at the composite endpoint, no difference. If you look at bleeding, there's a significant reduction in bleeding by more than 40% in the P2Y12 inhibitor group compared to the DAPT group. And that benefit appeared to be established clearly after the 90-day period. Even though this was a pretty large trial, the non-inferiority margin was quite large, and therefore we wanted stronger evidence from additional larger trials. And then came the Twilight trial. And Twilight is the largest of all of these trials. 9,000 patients who were randomized to receive either ticagrelor plus aspirin for 3 months, followed by ticagrelor alone for 12 months, or in red, a year of ticagrelor plus aspirin. And then after a year, randomized therapy was stopped and patients received standard of care, which usually was aspirin. To get into Twilight, you had to have high-risk criteria, which could be any one of the criteria on the left for the clinical setting: age, female gender, ACS, vascular disease, diabetes, or CKD, and to have one high-risk angio criterion: multivessel CAD, long lesion, thrombotic lesion, bifurcation lesion, left main or proximal LAD, or calcified target lesion. There were no STEMIs in Twilight. There were no patients on chronic oral anticoagulation, no rescue PCI. The results of Twilight are crystal clear. They are depicted on this slide. There was a very substantial reduction in bleeding, almost 50%, certainly more than 40% reduction in bleeding with monotherapy with ticagrelor compared to dual therapy. And there was no excess in ischemic events. Note that the confidence interval now becomes tighter because this is a large trial. We looked at subgroups in Twilight. We looked at the ACS subgroup, and here is the ischemic endpoints in the ACS subgroup. There was a consistent reduction in bleeding. Note that the ischemic events were 4.4% with placebo, 4.3% with aspirin. So dropping aspirin did not affect the ischemic event rate in this quite substantial subgroup of more than 4,000 patients. Results were consistent in those patients who had the most complex disease. Here they are. You can see that ticagrelor with DAPT in red compared to ticagrelor monotherapy in blue, there is benefit of monotherapy with ticagrelor regardless of whether there was complex or non-complex PCI. And there was no hint of an interaction. The hazard ratio is 0.54 for complex PCI, 0.54 for complex PCI, 0.57 for non-complex PCI. So clearly, bleeding is reduced whether you have complex or non-complex PCI, ACS or non-ACS, and you don't get an increase in ischemic events. Again, here, in the complex patients, the ischemic events were actually higher in those patients who had DAPT compared to ticagrelor monotherapy. This is CVDES, MI, stroke, all-cause death, MI, stroke, or stent thrombosis. And there was no statistically significant interactions between complex and non-complex PCI and the treatment group with respect to ischemic endpoints. But I think it's quite striking that you have this consistent pattern that patients who receive DAPT actually fare worse for efficacy endpoints than patients who receive ticagrelor alone. In diabetics, again, a reduction in bleeding and no excess in ischemic events. Again, numerically, the event rate in diabetics receiving ticagrelor alone was 4.6% versus 5.9% in those who received aspirin plus ticagrelor. And finally, this is the net clinical benefit, net adverse clinical events in diabetics for ticagrelor versus dual antiplatelet therapy with aspirin. And again, quite a striking and highly statistically significant benefit. Note that this was a post hoc analysis and therefore highly exploratory. The final nail in the coffin of DAPT came from the recent TICO trial that was presented at the American College of Cardiology a few weeks ago. This is a Korean trial in 38 centers that looked at ACS patients undergoing drug-eluting stents, and they were randomly assigned to dual antiplatelet therapy with aspirin and ticagrelor for a year, or ticagrelor monotherapy after 3 months. And again, the same findings. If you look at net adverse clinical events, the composite of efficacy and safety, it was numerically reduced and statistically significantly reduced with ticagrelor monotherapy compared to DAPT. Ischemic events were lower with monotherapy than with DAPT. Although this is not statistically significant, I think it's quite striking that this is consistent with what was seen in the Twilight trial. Contrary to what everybody would expect, adding aspirin did not provide better protection. There's a hint that it actually may be worse in patients who get aspirin, probably because since there is more bleeding, there is more interruption of DAPT and more secondary ischemic and thrombotic events. So, what can we conclude? We've had quite a journey through the trials. This is the guidelines that were put forward by the ESC in 2017 for DAPT duration in patients treated with PCI. And as you can see, there are really two different scenarios. Stable coronary artery disease undergoing elective PCI on the left, acute coronary syndromes on the right. If you have an acute coronary syndrome and you have a high bleeding risk, you need 6 months of DAPT in yellow. If you don't have a high bleeding risk, you need a minimum of 12 months of DAPT, class 1A recommendation. And then you have the option to extend DAPT beyond 1 year based on Pegasus, DAPT, and other trials using aspirin and ticagrelor, aspirin and clopidogrel, or aspirin and prasugrel, class 2VV. If you undergo elective PCI and you have a high bleeding risk, you need a minimum of 1 month DAPT, possibly up to 3 months. But if you don't have a high bleeding risk, you need a minimum of 6 months of DAPT, class 1A, and you have the option to extend beyond 6 months, class 2B, level A, with aspirin and clopidogrel. Since 2017, we've had additional evidence pile up. And I would like to point out that there are 2 new evidence-based options for selected patients. First, I think that Twilight, TICO, STOP-DAPT, SMART-DAPT, they changed the picture. And now we have the option of monotherapy with a P2Y12 inhibitor, preferably using ticagrelor because of the consistent efficacy of ticagrelor, started 1 to 3 months post-PCI. And then we have the option to extend long-term post-PCI therapy with aspirin and ticagrelor, particularly for diabetic patients based on the THEMIS PCI trial and the recent FDA indication. This is a complicated slide that I will not delve in detail that shows for every indication of PCI DAPT, the US guidelines and the European guidelines. And this slide merely states the finding that they are very similar. So how do I make decision for DAPT duration? Well, I think it's a multifactorial and a stepwise process. I will tend to use short duration for patients who undergo elective PCI. I think that by default, patients who undergo elective PCI generally will require a short duration. This is particularly true if there's been prior bleeding or high risk of bleeding, particularly a precise DAPT score of 25 or more. If the patient has a preference for discontinuing DAPT, if there is poor adherence, if there are planned surgical procedures. In contrast, I will tend to use longer duration for patients in the post-MI setting, particularly if they are older, if they have recurrent ACS, diabetes, abnormal renal function, or multivessel disease, if they have a DAPT score of 2 or more, anatomic high-risk factors such as a left main or multivessel disease, or procedural factors such as multiple, long, or small caliber stents. But again, I think that the recent advance in monotherapy might change all of this. And maybe what we need to discuss is the duration of ticagrelor. Maybe we don't need DAPT anymore following Twilight. And it's going to be interesting to see how guidelines committee around the world, in Europe, in the US, and elsewhere, will integrate the evidence from the recent monotherapy trials to guide decision-making regarding that duration. So my conclusion slide is the following. DAPT is the foundation therapy after PCI, and we certainly need DAPT for a minimum of 1 month, probably 3 months in everybody. But remember that we don't give DAPT solely to prevent stent thrombosis. We are treating patients, we are not treating stents, and the risk of stent thrombosis is relatively small. That doesn't mean that the risk of ischemic events is small. 2, DAPT using ticagrelor or prasugrel is generally recommended as the initial option in PCI for ACS. 3, the duration of DAPT should be tailored to the ischemic and bleeding risks. Certainly using bleeding risk scores such as precise DAPT appears to be a relatively straightforward manner to guide decision-making. 4th, based on Twilight and the similar trials, dropping aspirin 1 to 3 months after PCI may allow to maintain efficacy while reducing bleeding risks, particularly when using a potent P2Y12 inhibitor. And this is true also for ACS patients, for diabetic patients, and for complex disease patients. And this has become our own practice in my center. Finally, in selected patients at high ischemic and low bleeding risks, prolonged DAPT or prolonged ticagrelor appears beneficial compared to aspirin alone. I will stop here. I'll be happy to take questions during the discussion phase. And I would like to share this picture of the Eiffel Tower with you. And I long towards the time that we can be reunited face-to-face in Jakarta or in Paris. Thank you very much for your attention.
Thank you very much, Professor Gabriel Steg, for your very comprehensive, very clear, especially awakening us of all the landmark trial of antiplatelets in ACS and in post-PCI patient.